Good evening all, welcome to the third episode of Season 3, the DeBakey CV Live Innovation on the Loose. Streaming live from Houston Methodist here in the Texas Medical Center. I'm Dr. Stuart Cord, Director of Innovation Engineering for the DeBakey Heart and Vascular Center. Now tonight I'm delighted to have on the show Mark Lomax, CEO of Pep Health, and Kiel Christensen, Growth Manager for Pep Health. They're here tonight to discuss their AI-backed patient experience platform. Before we proceed, I'd like to invite the audience into our discussions. Please submit your questions via web at polev.com using DeBakey as username, or text DeBakey to 37607 alongside your question. And you can also add your question into the live YouTube stream. So Mark, Kiel, welcome to the show. It's great to have you on board.
Evening, Stuart. Delighted to be here.
So, like it or not, patients, when they leave hospitals, they're going to have an experience and they want to share that with the world. There's a lot of research, there's a lot of technology about how you get access to their information, like to the experience that they've had, because that's one of the most important things in healthcare. We want to offer the patient the best experience possible. But again, how do you use technology to make that happen? So Mark, tell us about Pep Health.
Thank you, Stuart. Delighted to be here this evening. I've got a few slides that I'm going to bring up just to walk you through the story of what we do at Pep Health. So let me just bring up my screen. So as you rightly say, Stuart, it is absolutely a key part to healthcare. Myself as a doctor, we recognise just how important this actually is. And it's not just important from the patient point of view. It's absolutely crucial as a business, as an entity that wants to look after more patients and to keep patients that are actually coming there, keeping them satisfied as well as we're able to do within the clinical environment. And this has been a long-term problem across healthcare to really understand that, because the surveys that we've been using in the US, in the UK, do not really reflect the patient views. The problem's multifold with them, but we know across the board that response rates are falling and people are busy and people don't necessarily just want to share their view back in the format that we ask from the very managed, controlled data collection that's often done through the patient surveying. And instead, patients are turning to the public environment. They're sharing their experiences on social media. They're sharing their experiences in chat forums. They're going onto online review platforms. Now, that is chaotic. It's really messy. It's all over the place. But actually, to use AI to unlock the benefits of that, we recognised was going to be a really important part of improving healthcare and improving the lives of patients. It started over 10 years ago, this journey, when there was something called the Mid-Staffs Inquiry in the UK, which looked at a really problematic hospital. And when they analysed what was going on, they realised that the patients themselves knew what was happening, but nobody was listening to them. The surveys that were being done, the focus groups that were being held, were missing this key fundamental problem that patients were talking about elsewhere. And so despite many calls now for improvements in patient experience, it has not been happening, and there's not been enough change to really try and find more succinct, more real-time ways to really unlock what patients really think. Here's just an example of one survey. This is the HCAP survey format, 7 pages long, really clunky. You need quite a lot of time. It comes in the post, it goes back. It also takes quite a lot of time, even if someone's willing to do all that, to get the analytics back. And that really isn't something that is really fit for purpose in today's age as a way to actually really understand it. And we're also assuming with this that the questions we ask are the most important questions. Now, are they really? Because actually a patient might be wanting to share something that's much more important to them. But in a tick box exercise like this, we're not giving the patients the opportunity to do so. So what is it that we do? And what is it at Pep Health that we've been able to unlock? So we now listen to over 100 million lives and their experience of patient experience. Across the UK, in Minnesota, and now recently in Texas as well, which we're very excited about. We collect all the comments, we filter them, make sure they're real patients talking about real episodes of care. And then we use that to both improve experience but to also derive better learnings to improve what can be done from a quality improvement perspective. That drives better outcomes for patients. For yourselves, it can really be used to improve stars ratings, and our functionality really targets the bits that really matter to help get a better stars rating, which thus improves reimbursement. And happier patients are much more likely to return, to be loyal, and to sort of be able to sort of promote that entity that they've had a good experience with people that they interact with day in, day out. You can see on the right-hand side there, that's a bit of a screenshot from our UK dashboard that a hospital uses. They see not only insights about themselves, but they get insights about their peers and their neighbours as well to really understand how they fit together. And the rankings that sit there too aren't just the rankings of every single hospital. It's the peer-to-peer affiliation of how do they measure against like-sized hospitals. We appreciate that an organisation with an ER department has very different challenges to something that's just pure elective activity with a very controlled environment. So we make it fair. And so when we do our benchmarking, we make sure that we're doing it in the right way to compare people together. Just very quickly walking through what it is that we actually do. There's 4 key steps to this process. The first one is that we map the landscape. Now, this has been a mighty big exercise. It's mapping every single location where care happens, either in a country or by a state. But not only that, we're also mapping it against diseases. We're mapping it against the drugs that patients are on, so that we can use our database to analyze the patient journey, either through their disease burden from early stage, maybe a big intervention, post-care, what's actually happening through that journey. We can map it all. We can also look at it from sort of the point of view of the drugs and sort of how's that sort of happening on that side. But for the purposes of today, really thinking about those locations, and that's the locations that right up and down the collapsing side of this. So if we start right at the top, we can look at it at a whole national level. Then we can drill down to a regional or state level. Then we can drill down into a health system level, followed by the hospital, and then finally to that departmental level. So we really know exactly what's happening where. To that mapping, we apply all the different comments we collect. We're currently undertaking a journey to map the whole of the United States, and sort of every hospital, every location of care across the states, which is a huge exercise. Since we started that, or even since the beginning of January, when we sort of started to expand out and accelerate this piece of work, we've identified nearly 100 million different individual URL codes where American individuals are posting comments about their experiences of care. Just gives you a little bit of a sense of the scale of how far and wide the net goes of where patients talk. We filter it for relevance. And then we start applying the AI algorithms to really start scoring and making sense of this within healthcare. So we tag it to the disease burden, we tag it to the location, we tag it to departments. Always scoring 1 to 5. 5's always the best for us, 1's always the worst. And when we've got all that side, we then cut it in a completely different direction, thinking about the qualities of themes within healthcare. And these are themes that are used sort of in a very similar format by the World Health Organization and other internationally respected bodies, so that we know that these are the things that really matter within quality overall. And then within each of these larger themes, we then have subdomains or sub-themes where we can really start to get pinpointed in what's really going on. So we know exactly what's happening. With all these scores, all this real-time information being generated, we feed that into dashboards and reports. The usual thing that we provide for somebody like yourselves is a real-time dashboard. Anyone in the organization can have access to it, and it really enables people to then interact. So you can either look at it at 30,000 feet, you can look at it at the ward level, and anything in between. These are the high-level quality domains that I referenced, just to give you a bit of a sense of what they look like. They also map very closely to the HCAP domains that matter for the stars ratings with CMS. You can see there, it's things like fast access, it's getting effective care, it's sort of the physical environment, the communication. The latest big theme that we generated was billing and administration as we entered the US market, because it's such a pain point for so many patients. And so people will go, well, yes, okay, you're not telling me anything new. I know that's a problem. But what we can actually really start to do is put a number to that rather than it being an anecdotal pain point. Is it the same pain everywhere? Or actually are some organizations doing a much better job than others? And that variation across the system, we can now really tease out and make sense of. So here's a little case study just to draw a bit of illustration to what I've just described. This is a snapshot of an NHS organisation in the UK that we work with. You can see a few lines on the left-hand side there. The ones that really matters, the orange line is the hospital, ordinarily above average, which is the two smoother lines. One's the regional, one's the national picture. But there was this period last year during last summertime where they really fell very quickly, and for a 6-month period or so had a real problem with their patient experience. It maps to actually that very hospital having a very challenging implementation of an EPR system that affected the whole of the organisation. So first of all, we picked that up. But the two things that, and why I thought this would be an interesting case study to share, is first of all, to make that even more stark, this is how they ranked versus their peers. And from being probably upper quartile for most of the previous year, they fell to pretty much the bottom decile through this period, really bringing to light just quite how stark that was. Now, at the same time, they were using their survey tools, which they've been reliant on for since whenever, many years, called the Friends and Family Test in the UK, nationally recognised, very respected tool. And here are the results through the same period. It was so positive and pretty much completely flat through what everybody knew was a very challenging period for patients and clinicians alike. And it just really goes to show that sometimes some of these tools that we've been using for so long and think, they are the truth. Well, are they really the truth? Or actually, are we able to really drill down and get more meaningful insights to that truthful picture nowadays? Taking it to the US, this is what we've now started to do in the US. And our journey in the US actually started up in Minnesota. And a mid-sized payer started to work with us about this time last year. And we're on a multi-year contract with them now, where we really support them with the delivery and supportive rollout of value-based healthcare. When we prepared it early 22. They went through a period of validation with us through the second half of 22 and compared us to the 8 existing solutions that they were using in-house to measure patient experience. And after that validation and that test exercise, we came out top to the extent that we've actually been made their patient experience solution of choice, which we're delighted about. Their STARS team of about 25 or 30, now uses our data to pinpoint where, why, and when do they need to make interventions to improve their STARS scores. They are now starting to share this with the health systems across Minnesota to really have meaningful discussions to improve quality for their members and to make sure that that's tightening or focusing in and zoning in on value-based healthcare really starts to grip across their system. This is sort of same area, but actually here's just a picture in one illustration of what's in the dashboard of all the different locations that we're listening to in the city of Minneapolis. And very quickly, you can start to see different colors for different qualities overall. You hover over any one of those bubbles, you can then click in, and then you can start diving down into all the detail and what's actually happening there to really bring it to life. And this we know is accurate, and we know it's empirically proven. We've had papers published in the British Medical Journal, we've been in the Lancet group, really showing that this is a meaningful new way of being able to listen to patient experience. So the journey in Texas and starting to bring it a bit closer to home for yourselves is towards the fall, we started collecting data across every single Texas hospital. So far, we've collected about 123,000 relevant patients across, I think, 369 or so hospitals in the state of Texas that we've identified. And the reason we started doing that is there's such an interesting ecosystem in Texas. with the Texas Medical Center, yourselves at Houston Methodist, and actually just that really nice combination of wanting to make things different and wanting to innovate with also a high Medicare Advantage coverage really makes it an ideal ecosystem for us to really pay attention to and to start to try and offer our insights to really support patients locally. We were able to present our first What Patients Think Texas at Health in Las Vegas in November. And we're so interested in the Texas ecosystem that we've actually applied for the TMC Innovate UK Edge Global Incubator Program that has just been, well, I think it might be today or tomorrow, applications closed for that. So people might be interested just to get a bit of a sense of what's happening in Texas at a macro level. And so here are a few things to share. The first one, which is actually unique in Texas of all the places that we're looking at, is that patient experience has increased on average over the last few years, which is great for Texans, but it does start to show a moving picture of what the new norm should be like. You can see with COVID, there was a blip. That is certainly a common thing that we've seen in many different territories and regions as well. But it starts to say, why is that happening? And that's something that we can now start to answer as well. First of all, here's the same data looking at every single hospital across Texas again. But we're now just starting to take the high level buckets of the themes of how we start to codify the comments. We can see overall in Texas, the emotional support, the effective treatments are the two that come out highest in a rating from 1 to 5. And down at the bottom, we've got a combination of the continuity of care and fast access that we're flagging up here as the two that sort of can be really problematic. It's not always consistent. And certainly when we start to drill down into the different hospitals and different health systems, the variation that we can start to see really broadens out significantly further. Similar thing, but just presenting in a slightly different way to bring this to life, is we can start to look at the variation across Texas regionally and what's actually happening. And we can see that whilst everyone has a sort of a higher than sort of the midpoint being 3 for patient experience, there's some pretty wide variation between these different broad areas where we can then really start to zone in on what's going to be the average in that space, but also what's the variation that starts to happen there. And we can start to zone in on what are the things that really matter to patients and what are the things that they're saying that they value most or value the least. And sort of just one final way of just looking at Texas as a whole to bring this to round it off together. On the left-hand side, we can see all the different regions that we've coded this across Texas. This, again, is all the hospitals grouped together. And then we're looking at it by some of these high-level themes that we can cut it by. And we can start to see where people are particularly strong and where they start to vary from it. And just looking sort of from top left to bottom right in that grid, you can see sort of best sort of as a theme would be emotional support in Central Texas with a 4. And then down in the bottom right-hand corner, we've got continuity of care sort of within your part of Texas. So it starts to sort of really start to tease apart that we start to get some really meaningful differentials. And again, just to remind people that the methodology behind this and the scoring and the accuracy has now been empirically proven, and we know that these scores really matter. So finally, just to wrap up for everybody, a few things to think important takeaways. This is a completely automated solution, which makes really rich, meaningful sense of what patients are thinking. Empirically proven, and that can be used both to increase revenues and improve quality for users. We're actually completely data agnostic. So I've really sort of been talking about what's in the public domain, of which there is a vast amount. But many organizations have many different sources of ingesting and collecting data from patient feedback, do surveys, do focus groups. We're actually data agnostic. So we can process all of that through our AI solution and bring that together into one 360-degree view in our real-time dashboard, which is actually sort of a really simple, easy to use outfit. And that sort of journey is going to take us to being able to capture the whole of the US, say, by the end of 23. So we can then compare any which organizations together at any level, which we're hugely excited about. So to summarize, or sort of to pose a question back, Stuart, can Houston Methodist handle the truth?
So it reminds me of that film, Mark, you want the truth, you can't handle the truth. I'm going to jump straight in with some questions, but can we go back to the slide there that had the state of Texas on it there with some of the comments? I'd like you to read through some of those comments just to make sure our audience are seeing the type of comments.
Sure, let me just jump back.
So what are they saying up in the Panhandle, Mark?
So up in the Panhandle, we've got a couple of comments there. We've got one here, all they care about is money. And we've got another one, very unprofessional, talks to other people and violates HIPAA. Do not recommend her to help you with your medical needs or even your privacy. It's small print, so I appreciate that people might not be able to see.
What are they saying up near Dallas in East Texas? What's happening
up there? Excellent services, very caring staff, thanks. I was very pleased with the professionalism concern showed me when I was an outpatient, if necessary. I would not hesitate to choose again for my health needs again. And then down in the Houston area, patient care was very good. At times, too many doctors. Communication between nurses and doctors at times was rather difficult. Food was good.
Got it. So I mean, just looking at that, it looks like though, obviously we're looking at the dark green are better patient experiences, correct?
They are. I mean, these are just a few that we've just sort of pulled out sort of rather randomly just to illustrate that we can tag and locate them together. So they're not particularly necessarily representative of those patches, but it's just to try and sort of bring this to life in terms of sort of what's out there. And
just to let our audience know, this original slide actually had the names of the hospitals where those comments came from. And thank you to Mark for omitting that. We don't want to get into any weird Leo territory. But I think it goes to the point that, you started getting that data back in October 2023 and you've got 173,000 data points, whatever it was. And you can constantly get new data coming in, right? I mean, your thing, is it working like kind of 24/7 if you want it?
It is. I mean, this is sort of something that constantly working through the night and day. Just to sort of go back to your comments as well there, Stuart, one thing to really stress is that all these comments that we've collected are in the public domain. So we're not breaching anybody's privacy. None of this is a private message that we've inappropriately collected. But it's very hard to bring this whole picture together. A lot of the generic sentiment analysis tools and the tools that hospitals often use to monitor their brands, they'll listen to your Facebook channel, they'll listen to your Twitter channel, but they won't reach the recesses and the corners of this where patients are talking to their communities, they're talking to fellow patients, they're talking with a way of tagging you and talking about you, but so much of that is getting lost with the existing technologies that are only capturing a very small amount of this commentary that's happening.
Got it. And to add to that, I've actually had some really good questions here from our DIOP team. Like Courtney Bruce, for example, sent some really comprehensive questions here. So one of those questions is regarding accuracy. So is the data consistent with what we're seeing using things like the NRC Health, which is the National Research Corporation, companies like Vizient, the CMS, so Centers for Medicare and Medicaid Services, in their hospital consumer assessment for healthcare providers and systems, or HCAPS, which is shown, and also our own internal surveys and patient and family advisory councils and market research, etc. So that seems to be the current standard. So how do you guys differentiate from that? And maybe if you want to give us some examples as well of the current standards, and I know Kyle had his own patient experience with that.
I will. Well, I'll say a little bit, and then maybe Kyle, you jump in and add some bits from your own experience. So our journey's been longer in the UK, Stuart, but in the UK, where we started, and the first paper we actually had published was just by listening to this patient voice in the public domain, we could accurately predict what the UK regulator, the UK healthcare regulator, would find when they went in to do an inspection of all the different hospitals up and down England. And it was the most read article in one of the BMJ circulations for about 6 months. And it really sort of shows that this is accurate and it's meaningful in the real world. We've now done that on multiple occasions. We've done it with a variety of different public data sets based in the UK. So we know 100% this is accurate and meaningful in the UK. What about in the US, you're going to ask me? Well, we've started looking at it from the HCAPS perspective. And with that, the overall results are in the public domain, so we can now start to correlate, and we're doing that up in Minnesota to actually see what that correlation is like. Early work is looking really promising, that we can see that there's a really distinctive correlation, but on the other side, what we're also finding is new and meaningful insights that we validated by sharing them with other health systems who've actually said, well, we knew some of that, but we didn't actually appreciate it went that far, and we didn't appreciate that actually this was actually what it meant, whether it be on a timing point of view or in an effect, that things that they thought were maybe a minor deal locally were having a much more meaningful effect on the patients themselves. So to this, and we know sort of that those themes that we have correlate really neatly into HCAPS and CMS. Now, there's a lot of different tools, and we're not saying that we're sort of the only solution that should be used, but what we do think is that we add a really meaningful additional layer of really new insights and new ways of not only being able to look at yourselves, but also being able to look at yourselves in comparison to people that really you want to benchmark yourselves to, or think of the right benchmark group to compare yourselves to. Kyle, do you want to add in?
Yeah, absolutely. So the best example that I can give is this last summer. I have one of my children went to the emergency room and was admitted, was there overnight, and several days, a week, maybe 2 weeks after, they send out the HCAP survey. As Mark mentioned, it's many pages, 29 questions. It asks about the quality of care that the nurses and doctors at the facility that you've received. It was the last thing on my mind. I didn't pay any attention to it. I threw it away. I was making sure that my children were recovering, and obviously, I'm not the only one that feels that way when it comes to surveys. And the idea that patients are going to share everything within a 1 to 4 metric that is on their mind in a checkbox format, I don't think it aligns very well with what actually happens with people when they go to the hospital, and the insights that a hospital would hope to gather is going to come from free text. You have to give a patient the ability to say what was important to them, and you have to be able to capture all the different lines, whether it's fast access or billing and administration or any of the other quality domains.
So do you know what the average rate is for patients who actually fill out like these forms, etc.? Is that kind of out there, or?
So it varies, but typically 5 to 10 years ago, people would be delighted if they could get a 30% response rate. Now people would be happy if they can get a 20% response rate.
So it's going down, I guess.
It is. It's shocking.
Now, another question we had is how insightful kind of is your technology? Some hospitals, they already know they have a problem, right? So if they were to bring your tech in, you're kind of preaching to the choir, you're telling them a problem they already know about. So how can you offer things that you maybe don't already know? I mean, you don't know what you don't know, right? But has there been use case scenarios where a hospital has discovered something that you just did not know about?
So there's a couple of different things that sort of how that gets used. The quality improvement teams really like to use our technology to really track other initiatives that they make. So let's just say they change how they're operating their outpatients, and they want to change that all around. Has it actually improved their patient experience or not? They don't know, but they can use our tool to actually track these things in real time. So they can literally do A/B testing in a healthcare environment without having to do anything different, and we'll give them an immediate answer back in terms of, is that metric changing or not? There's also the thing of, well, we know we've got a problem, let's say in the ER department, the waiting time's too long, we haven't got enough staff, we're really struggling. But is it getting better or not? And if we try some initiatives during that process of maybe trying to manage the expectations of people as they come in, or giving them regular updates. And we actually find, and as you're probably aware, Stuart, in the UK at the moment, there's some really, really big challenge problems with accessing ERs and that emergency care side. But it's not a uniform picture. And actually, I've been able to identify some organizations doing a really good job. And what they're doing sort of with communication and trying to create new ways of being able to manage that process that really have an impact. And we can immediately tell them, have they had an impact? Is it getting worse? And where are they on that journey? And then the final part to then is giving them the benchmark of, well, relative either to your local peers or your national peers, this is how you're measuring up. And you might not be getting a better score, but others are getting worse. And so relatively you're improving, or sort of whichever way it might be. So hopefully some of those pictures and diagrams that I shared with you should really bring to life the breadth and the range of different insights. And none of this is us saying, this is our opinion. This is us purely holding up a mirror to say, this is what we're hearing from patients. And a more representative group of all patients that are out there, rather than perhaps a narrow profile that is more likely to fill in the surveys, or to at least sort of send them back in. So
what kind of mechanisms do you guys have in partnership with hospitals to validate those comments? I mean, Twitter, for example, is plagued with bots, as Elon Musk was kind of telling us, right? So, how do you know that it's not a bunch of like nefarious bots out there just saying bad things or good things about the hospital? How can you verify that?
Yeah, so we have a range of different tools to filter for relevance and to make sure that people aren't trying to gamify the system. We're always alert to that, and it's not just sort of the likes of the bots out there. We actually sort of had a rather awkward conversation with one hospital where we identified certain departments had nurses filling in the patient experience forms themselves, and our AI could recognize that the language patterns were not suitably varied, and the grammar usage and the syntax were of such patterns that it just sort of we were able to flag it and go back, and actually sort of it did turn out that the nurses were filling in the patient experience forms themselves. So there's that, different sources. Sort of we're pretty good now at sort of being able to have never a 100% sort of it can never get through, but actually if there's one area that's really trying to game the system and it's starting to generate either strange volumes of comments or skewed very quickly from maybe a 3 on average to a 5 coming through in quick succession, these things get flagged, and then we have internally a language team that then go and sort of manually sort of take a look at those bits to see whether it should pass or whether it should be screened out.
So I mean, straight away it'll be very interesting, when we get those kind of annual reports. I mean, you were saying before the interview that some of these reports like the CMS, HCAPS, whatever, they only come out once a year, right? So
there's a whole range. Exactly.
So I mean, just where I was going with that, Mark, is just saying, it'd be very interesting that when these come out, you guys could also publish your own reports to see how they compare. Like the Pep Health annual, because I think that would be very fascinating to see the comparison in that.
It definitely would, and that's the sort of thing that we'd really love to do locally. We've done it now with publishing a few different papers called what we call What Patients Think. And with those, what we did was we took various things like the CMS results, but anything that's in the public domain that we can really benchmark ourselves and compare, but they're only intermittent, and then fill in the gaps and say, well, actually, yes, that was true 12 months ago, but now the situation is looking very different, and it looks like this. And one of the challenges with those types of publications is you end up having a rather difficult conversation saying, well, Yes, but we think we fixed all that. But then you don't know whether it has been fixed or not if you're responsible for it. And then you're waiting for the next survey to come along to give you any further updates, or you do a mock survey yourselves to fill in the gaps. And you're never 100% sure where you're actually at with that because you're not doing it in real time, which is one of the neat things that we're able to fill in the gaps to.
Got it. And again, apologies for cutting you off earlier, but I want you to continue what you're about to say, because it sounds like you were going to talk about the periodicity, how often these surveys publish.
So there's a whole range, but they're all just intermittent, unfortunately. So there are things that are annual, there are things that are half yearly. It's very bitty, and a lot of this is done still through the postal network, which then indeed just creates even more lag and expense and clunkiness. And then there's so much manual effort that goes through the whole process before anything meaningful is coming out the other side. And it feels a hugely analog world that's existed like this for decades that hasn't really had the level of innovation, and people thinking, well, should we not rethink this when we've left it be for so long, when other parts of healthcare have just completely transformed themselves. And so we're excited about being on that journey. We recognize that the more proof points, the more evidence, the better it is. We have a few papers that we're starting to work on now to sort of be published with US evidence, but that's sort of the ones that we're now working on is with our payer that I mentioned sort of during the presentation. We'd love to do some of that on the provider side as well and bring that to life so that we can really look at both sides of the coin to see how that fits together.
Got it. And I think the last question I have is the implementation of your technology. Are you guys completely standalone, external, like subscription business model, or is it the case you've got to integrate internally with existing hospital architecture and IT, etc.?
Yeah, no, great question, Stuart. And the nice thing is that it's super easy to do. Appreciate that people are so busy. There's so much sort of effort that's been put in across healthcare. What you don't want is a really difficult implementation. So for us to be able to operate, there's really two questions that need to be sort of addressed up front. One is more an information sharing to us of what's your business architecture look like, what are the business units, what are the divisions, what ward does what activity, so we can really accurately have a good map of the local hours, local service provision across the health system, so that we can configure the dashboard accurately, which we can do ourselves quite straightforwardly. And then the second part is, would you like to share all the other existing patient experience comments with us as well, so that we can ingest and then bring it together so it's a one size 360-degree view, everything together. And we can do that as well to provide that services. That all then becomes a web accessible dashboard. Anyone with authority can be given access to use it. And that is, we provide training, but usually people go, this is just so intuitive. It tells me what I need in so many easy ways, visually and diagrammatically, that it's so straightforward. It makes it easy. We do have a bit of an idea for a longer term roadmap that it could fit into existing architecture, start thinking about linking patient experience to the EPR system so that we can actually flag up to patients and be much more, have a precision service for each individual, recognizing their past experiences and what matters to them and what they really value. But that is not what we've got on offer today, but hopefully that could be something we could offer patients in the future.
Got it. So I mean, it's very clear. I mean, it seems that you guys have you've got something unique, innovative to offer, and sounds like you're ready to go. Yeah.
We're enthusiastic, and we spend most of our time sort of on US activities one way or another these days, and I think sort of we just see this as having such a positive impact on patients, on the organizations that engage with the data, making their businesses more successful, making patients want to return more, that this becomes a real win-win for everybody in the system. So we're really excited about what we could do, but we've loved having the discussion so far with yourself, Stuart, and hopefully we can sort of become a more regular engaged member, both to Houston Methodist, but also to the TMC, which we'd be super excited to do this year.
Superb. And just a side note, I think it'd be really funny actually, or interesting, to see the different types of comments from geographical regions in the UK, for example. Like, imagine someone in Glasgow may say something different to someone in Manchester or London or Leicester, and Same over here in US, they might use different vernacular, right? Different vocabulary, say different things.
They absolutely do. I actually just had a meeting. So I live in Minneapolis, and I met with our language team, and they were asking me about specific grammar that was used, and across the U.S. I'm a Midwesterner, so I gave them my 2 cents. But yeah, absolutely, that's one of the best parts about having a language team that is very skilled. Is they pick up on these things, and they ask a lot of really smart questions. Whether it relates to parking or food or just medical terminology, the names of facilities. It's been very, very interesting.
Well, on that note, I'd just like to thank you both again for joining the show. And Mark and Kiel, it's been absolutely fantastic having you on board, and wish you all the luck in the future. And thank you to our audience as well for participating and watching. This will be made available on YouTube on demand, so if you can't watch it today, just watch it when you want. On that note, thank you very much, guys. Thank you all. Goodbye.
Thanks, Stuart.
Goodbye.